Good afternoon, everyone. Welcome to this short symposium called as the Retina Updates. We'll be discussing few interesting topics. I will invite our chairperson, Dr. Lalit Verma, on stage. Our co-chairperson, Dr. Mahesh Shanmugam, sir, please. And I have Dr. Unni here who will be leading the panel discussion. First, we have an interesting talk by Dr. Padma Malini. She'll be talking to us on the role of anti-VEGF in the management of inflammatory new vessels in uveitis. I think we are so used to treating our DMEs and our CNVMs. Dr. Padma will throw some light on how she manages inflammatory new vessels. Over to you, Dr. Padma.
Dear friends, I'll be talking to you on role of anti-VEGF in the management of inflammatory new vessels in uveitis with case examples. The outline of my talk includes the introduction, the role of anti-VEGF agents, what are the imaging modalities we can use to document and monitor the new vessels, and management.
Hold on. 1 minute. This slide is something different actually. This is a different slide. ये वाला नहीं, जो मैडम का है ना?
This one. Thank you. Sorry. Imaging modalities and management options with case example with take-home points. In uveitis, we have inflammation which lead on to ischemia, which in turn causes new vessel formation. So next, treatment includes anti-inflammatory agents and also the anti-VEGF agents. The sight-threatening vision complications in uveitis, which are VEGF-mediated, includes cystoid macular edema, choroidal neovascularizations, and retinal neovascularization. Anti-VEGF in uveitis is primarily indicated if the patients have macular edema, choroidal neovascular membrane, retinal neovascular membranes, and cases were intolerant to systemic steroids or refractory to therapy. Anti-VEGF agents is combined with systemic steroids or immunosuppressive agents to achieve the disease quiescence in uveitic eyes. Intravitreal anti-VEGF agents per se can cause increase in inflammation in pre-existing uveitis, or it can cause reactivation of diseases like VKH and sympathetic ophthalmia. So we have to cautiously use these agents in inflamed eyes. Intravitreal VEGF level in uveitis patients treated with uveitic macular edema with Biosimilar, the results are well known in the literature. So VEGF plays an important role in the pathogenesis of uveitic complications such as cystoid macular edema, choroidal neovascularizations, and retinal neovascularization. The blockage of VEGF has not shown to have anti-inflammatory effect. Coming to the new vessels, in the anterior segment, they can present in the pupillary margin and the periphery of the iris. They can cross the scleral spur. They are thin, arborizing, and fenestrated vessels, poor blood aqueous and blood retinal barrier, leading on to leakage of the vessels. Coming to the imaging modalities, the anterior segment new vessels can be documented with anterior segment angiography, the wide field fundus photography, and we also have angiography like fundus fluorescein angiography, indocyanine green angiography, and also OCT and ARCTA to study the choroidal changes. Coming to the management, when the patients have neovascularization with uveitis, we see whether it is associated with inflammation or without inflammation. If with inflammation, the preferred drug will be an anti-inflammatory therapy in the form of corticosteroids. They can be given in the form of topical, systemic, periocular, or intravitreal steroids. Topical non-steroidal anti-inflammatory agents also can be used as an anti-inflammatory agents. If inflammation is significant or severe, we use systemic immunosuppressive therapy. The severe cases like Behçet's and ANCA-associated vasculitis, those kind of conditions, we use biologics. And anti-VEGF agents, the preferred ones are Biosimilar, Ranibizumab, Biosimilars, and Biosimilar. Next, the Biosimilar and Ranibizumab can increase in intraocular inflammation in uveitic eyes. Without inflammation, if they have neovascularization, anti-VEGF will be the first drug of choice, followed by laser photocoagulation. We'll move on to the case examples. A 30-year-old child presented with left exotropia. Fundus examination revealed bilateral healed toxoplasmic retinochoroidal lesions. We made the diagnosis of toxoplasma based on the serology. OCT was performed over the lesion, in which we can see the choroidal neovascular membrane with intraretinal fluid. Child received injection Biosimilar, and we could see the resolving SRF in this child. Now the child is 7 years old, has recently had reactivation of toxoplasmosis. Subsequently, the child received 2 more injections of Biosimilar. OCT was monitored. 1 year later, again reactivation of the CNVM with SRF. Here, the child received 3 doses of Biosimilar, following which there was resolution of the CNVM in this child. The next case is a 57-year male, diagnosed case of idiopathic panuveitis with secondary glaucoma, presented with prominent vessels in the right eye, where we could see the inflamed iris vessels in the anterior segment of the eye. We stepped up the topical and systemic steroids, following which we could see the resolution of the inflammatory vessels in the anterior segment of the eye. He presented 2 months later with neovascularization of the iris in the left eye, with increase in intraocular pressure. He gave intracameral Biosimilar injection. When we did a tear cytokine analysis, we noticed increased MMP9, iris vessels treated with steroids. In June 2022, we also noticed increased VEGF levels. At that point of time, in addition to the steroids, we also used anti-VEGF agent in this patient. Next case is a 13-year-old girl referred as a case of a bilateral panuveitis, where we could see the neovascularization on the disc in the left eye. Here we see the disc leak, diffuse perivascular leak with neovascularization, found pattern of leakage with disc hyperfluorescence, diagnosed have a Behçet's uveitis. This child received systemic steroids, immunosuppressive therapy with methotrexate and injection adalimumab, following which we could see the resolution of the inflammation and disappearance of the new vessels in both eyes. Next case is a 16-year-old boy presented with history of sudden onset of defective vision in the left eye, history of travel. He also gave history of fever 2 days back. And on examination, we could see a bilateral retinal vasculitis with classical Candleback's drippings were seen, hyperemia of the disc, periphlebitis is seen, and neovascularization of the L's seen in the right eye, where we could see the neovascularization elsewhere. On close follow-up, we could see in addition to the vasculitis, you can see a focal areas of retinitis in the left eye. OCT shows hyperreflectivity with aftershadowing. This is an FFA picture showing the disc leak, staining and leakage from the vessels, neovascularization with capillary non-perfusion areas. On investigation, this child diagnosed have increased serum ACE levels suggestive of sarcoidosis. In addition to that, OX2 and OX19 was also positive on wheal filix, suggestive of a rickettsial infection, which correlates well with the clinical findings of focal retinitis in the left eye with Candleback's drippings in both eyes. So we made the diagnosis of posterior uveitis secondary to sarcoidosis with rickettsial post-fever retinitis. We treated the patient with doxycycline and oral steroids, did the targeted laser photocoagulation for the capillary non-perfusion areas. Subsequently, we started the patient on systemic methotrexate therapy. We also have done the tear biomarker analysis. In that, we noticed increased ICAM and MMP9 in the right eye. In the left eye also had both MMP9 and ICAM1 was elevated. Subsequently, there was a persistence of inflammation. When we did that, at that point of time, increased MMP9 was high. We have to put the patient on intravitreal steroid Osidex implant, following which there was resolution of the inflammation. Here, the clinical persistence of inflammations correlated with increased inflammatory markers in the tears. The next case is a 45-year-old female presented with both eye laser PDR with florid NVD and vitreous hemorrhage, diagnosed with syphilitic retinal vasculitis. Patient was partially treated with syphilis elsewhere. Here we could see the florid NVD with vitreous hemorrhage in both eyes, disc hyperfluorescence, perivascular leakage with block fluorescence corresponding to the areas of the vitreous hemorrhage on FFA. Investigated both specific and non-specific, that is treponemal and non-treponemal tests, both TPHA and RPR was positive. Diabetic status was under control. We referred the patient to the infectious disease specialist, restarted the patient on antisyphilitic treatment. Patient also received doxycycline, and you could see the resolving pan-uveitis with vitreous hemorrhage in this patient. Started on oral steroids, and patient received intravitreal bevacizumab injection to both eyes, following which we could see the resolving NVD and vitreous hemorrhage in both eyes. Subsequently underwent 3 more injections of anti-VEGF into the right eye and 2 injections in the left eye, along with targeted laser was done for the right eye, and oral steroids was continued. So resolving uveitis with neovascularization we saw. We also have done the tear cytokine correlation, which correlated with decreasing MMP9, ICAM, and interleukin 17A and TNF of this patient. It was high in the presentations. Following treatment, there was a resolution. Can you take 1 minute more? 1 minute more. VEGF level also we can see it's gradually declining. Here is a case of a 32-year-old lady presented with defective vision and flow tests, diagnosed of a granuloma on ATT and systemic steroids. Here you could see the hyperreflective in the outer retinal layer with hyperfluorescence on ACTA. This particular patient received ATT steroids. The granuloma was regressed. 4 years later, patient presented with defective vision in the left eye, where we could see the neovascularization on the surface of the granuloma, which you could see it on ACTA. However, there was no activity of the granuloma. So, the granuloma was vascularized without reactivation of the uveitis. Patient received 2 doses of anti-VEGF without steroids, following which we could see the resolution of the new vessels on the surface of the granuloma. Here again, we did the tear cytokines which correlated with increased VEGF level with the granuloma, vascularized granuloma, following which there is regression of the vessels and decrease in the VEGF level from the tears. 34-year serpiginous-like choroiditis. Fundus autofluorescence shows hypo with hyper-autofluorescence. ACTA shows the choroidal neovascular membrane. So this is the OCTA findings, where we noticed deep spacing between the larger vessels were increased, deep vessel density was decreased, and also we have seen the capillary free zone corresponding to the areas of the choroidal neovascular membranes. The deep vessel density had the highest area under curve compared to the other vascular parameters. So capillary free zone had increased active CNVM compared to the normal eyes. This is a summary of the cases. We managed majority of the cases. In addition to the anti-inflammatory, anti-VEGF agent was used. To summarize, in uveitic new vessels, we need to treat the underlying disease. Either it's infective or inflammatory, we have to treat them with appropriate anti-inflammatory therapy. Inflammatory new vessels respond well to anti-VEGF therapy. Clinical imaging and biomarkers can correlate with the disease activity. Capillary free zone acts as a significant parameter to distinguish between the normal and choroidal neovascular membrane on ACTA. Each case, we need to tailor-make approach to treat inflammatory new vessels. Thank you for the opportunity. Thank you for, these are my acknowledgements, and thank you for the attention.
Thanks, Malini, for this wonderful 6 cases you shown. But the message should go that in inflammatory disease, only if you have new vessels, then only you give this trial of anti-VEGFs. Otherwise, inflammation does subside with anti-metabolites.
Anti-inflammatory therapy itself.
So those still remain the mainstay of treatment. Only if, suppose you get a treatment naive first-day patient who has all these features, will you start steroids alone or you will still add anti-VEGFs?
We start the steroids, see the response, and then add anti-VEGF if still the inflammation vessels
Yeah,
are
because I have
persisting.
seen patients who respond to steroids alone also.
Yes, I have seen one case,
Yeah.
Bechet's case, where responded to steroids and anti-inflammatory therapy.
Yeah. So anti-VEGFs are not the mainstay, but only if they are complicated by formation of new vessels.
Associated neovascularization, then we give anti-VEGF.
Mahesh,
One probable exclusion would be an infective granuloma, because tubercular granuloma you would give probably intravitreal moxifloxacin plus an anti-VEGF. That works. In even the presence of an active inflammation, you can do that.
Yes, in active TB granuloma with the vascularization, we inject anti-VEGF along with moxifloxacin as like sir.
I think one major contraindication for any anti-VEGF is pre-existing inflammation. That's what we, retina people follow. We tend to avoid it, especially if there is early pre-existing inflammation. So have you ever seen worsening of the inflammation? Yes, the vascular component has come down, but post anti-VEGF in any of these patients, did you see worsening of the inflammation?
We did see in other patients, not in this, but they have minor flare-up like vitritis, and they settle down with stepping up of the corticosteroids.
Systemic or topic?
It depends upon the type of the uveitis, and most of the times increasing the frequency of the topical along with stepping up of the oral steroids.
There's a subtle difference between an inflammatory CNVM and a CNVM in a post-inflammatory eye with recurrence. What would the indications to be to make out those two?
So inflammatory CNVM is majority of the time it's type 2 kind of a CNVM, and in an OCT, in addition to the CNVM, we also have other inflammatory signs like presence of posterior vitreous cells, intraretinal fluids, subretinal fluids, and increased choroidal thickness, or in case of a granulomas, that will help us to differentiate from other entities.
Okay. So just to add to that, one of the points where you would give an anti-VEGF very early is if it's a very juxtafoveal CNVM just abutting the fovea, and on Octa, if you can see actually an advancing edge towards the fovea, you would be have a low threshold of giving anti-VEGF very early, even if it is in the inflammatory stage.
Any other questions from the audience?
and any choice of anti-VEGF agents?
I do not have any financial interest, and
But any agent should suffice.
anything they respond well, but if it's persistent, recurrent, then they respond better to aflibercept.
Would you want to avoid a biosimilar in these? I'm sorry, I think I'm in the wrong hall. But anyway.
Controversial.
Yes, preferable. We have seen quite a few patients with flare-up of occurrence of inflammations. We generally tend to avoid.
Madam, the reason for neovascularization in these uveitic eyes is that inflammation is not under good proper control.
Yes.
But with an anti-VEGF, definitely it will disappear. And do you also hike up, along with the anti-VEGF, always do you hike up the dose of the immunosuppression for these patients, so that because the next time the neovascularization is going to come, or if we are able to understand that the immunosuppressive dose is not good enough, is after 6 months, because the next neovascularization will come after 6 months. So will you always hike up the dose of immunosuppression along with the anti-VEGF? Because some of the cases, just by hiking up the immunosuppressive dose, the neovascularization disappears.
Yes. Definitely, the basic mechanism itself, the inflammation is not kept under control, the ischemia and then the new vessels. So definitely anti-inflammatory therapy not only controls, will prevent the recurrence of new vessels. I agree.
So next.
And more importantly, what we find it useful in posterior uveitis, targeted laser photocoagulation, if there is a CNP areas, FFA-guided laser treatment, definitely plays a role in preventing the recurrence of new vessel occurrence, in addition to inflammation.
So thanks, Dr. Padma Malini, for some insights into inflammatory new vessels and uveitis. I
Thank
think
you.
We'll
Thank
have
you.
biosimilar talk later on.
Yes, sir.
Let's finish up with PDR, Gopal
PDR.
Pillai.
Okay.
So, normally I would not advocate anti-VEGFs in PDR. But laser should be the mainstay unless...
Let us see, sir.
Let me introduce Dr. Gopal Pillai. Okay.
So we all know that proliferative diabetic retinopathy, laser is the mainstay, like Lalit sir right now told. So laser will be absorbed by melanin, and then it decreases the oxygen consumption to the outer retina. And then what happens is that through these scars, oxygen would come in, and the need for oxygen also reduces, and that reduces the VEGF production and reduces the neovascularization. Why would anybody use anti-VEGF? So PRP is the gold standard, but sometimes there can be macular edema worsening, or and then decrease of vision, peripheral vision, night vision. So all those problems also come with panretinal photocoagulation. And despite PRP, a lot of patients lose vision, and so there is an unmet need in some patients. So how does anti-VEGF act? It inhibits the VEGF level temporarily, so which means that the patient may require multiple. So laser reduces the stimulation of the retina to produce VEGF. So on the one hand, we can reduce the VEGF, and the other hand, we can reduce the stimulus to form the VEGF. So both are complementary. Now this is a patient who has cataract, moderate looking NPDR. So what happens is he underwent an uncomplicated cataract surgery and came after 6 months, and you can see that he had a bleed now. So maybe there was a small, neovascularization, or in 6 months he formed a neovascularization after cataract. So whatever it is, a laser was not possible at that point of time because of the cataract, and that is why, so such cases in which an anti-VEGF along with the cataract surgery or just before the cataract surgery can prevent these complications. This is again a worsening of diabetic macular edema after cataract surgery. After 3 months there was a worsening, and sometimes there can be proliferative diabetic retinopathy along with diabetic macular edema, and some large fronds which are flat but not so much elevated, in which a laser may precipitate bleeding. So we have 3 studies: Protocol S, Proteus study, and Clarity study. These are 3 studies on proliferative diabetic retinopathy where the effect of injection was studied. In Protocol S, it was like, initially it was planned for 2 years to anti-VEGF versus panretinal photocoagulation, efficacy and safety, and adults with type 1 or type 2 with no prior PRP and vision score 24 or 20 by 320, that was basically taken. And prior PRP, TRDs or traction, neovascularization of the angle, dense cataract, all these were excluded also. So out of nearly 400 patients, about 200 were randomized, and 2-year visit was about 168, and 5-year visit was about 117 and 123. So about 60% of patients completed 5-year results. So here, the treatment schedule was 3 injections of ranibizumab was given monthly, and then at 4 monthly effect. If it is resolved completely, then you defer the injection. Improved or stable, you will re-inject. Whereas PRP, at 16 weeks, the clinician could decide whether to add PRP, or if there is a vitreous hemorrhage or something like that, we wait for 2 months and then do a vitrectomy. So this was the criteria, and there was a rescue criteria also, failure and futility. So if there is a failure, then you would go for a panretinal photocoagulation. Associated DME, if it is more than 250 microns, was treated, and a treatment given for 12 weeks and then continued. So follow-up schedule was every 4 weeks for the first year, and depending on the clinician's discretion later. So after 5 years, you can see that ranibizumab, there was 117 and PRP 123 eyes, and this is the change in visual acuity is almost equal. By 5 years, you can see that both the graphs, initially there was an improvement for the anti-VEGF arm, but by 5 years they became almost equal. That is about 3-letter improvement. Worsening of 10 letters. Was higher, almost 1.5 times higher in the PRP arm, and 15 letters was about 8% and 10%. By 5 years, it became 6% and 9%, still about 1.5 times higher of worsening of 10 letters. All right. Visual field, yes, there was a significant change. The laser arm had worse visual field than the ranibizumab arm. But at 5 years, there was some change in the ranibizumab arm as well. Vision impairing DME was more in the PRP group, almost double in the PRP group alone as compared to the ranibizumab group. So how many injections were required in the first year? Because there were 3 loading injections, 7 injections, and then you required approximately 3 injections every year. So there were 26 eyes who had to undergo rescue therapy with PRP, and PRP, about 71 eyes or 58% at least, one ranibizumab injection for diabetic macular. About 60% of the patients had ranibizumab injections. Now, if you look at total who received vitrectomy, again, double the number of patients who underwent PRP alone underwent vitrectomy as compared to the ranibizumab group. About double the patients had vitreous hemorrhage, and double the patients had traction retinal detachment in the PRP alone group. Adverse events, there was not so different actually. Ranibizumab is as effective as PRP, and 5-year results, the vision was good and no increase in serious complications and less visual field as compared to PRP. So more than half of the eyes in the PRP group received ranibizumab for diabetic macular edema, and ranibizumab treated eyes were less likely to require vitrectomy, and cost and risk of worsening disease if patient was treated with ranibizumab fails to return for appropriate follow-up was not considered. All right. So is visual acuity the only concern? We did not have fluorescence. Visual field loss in the ranibizumab group also at 5 years showed some decrease, and with 40% dropouts, there was some problems with the study. Then we come to the next study, the Proteus study, the ranibizumab plus panretinal photocoagulation versus PRP alone for high-risk PDR. We looked at regression of neovascularization. Okay, so baseline visual acuity changes and neovascularization and time to complete neovascular regression. There was 3 loading doses followed by 3 doses of PRP, and the other one was standard PRP. So, ranibizumab with PRP versus PRP alone, and looking at neovascularization, regression, etc. So 92% showed regression with the combination treatment. With PRP, only 70% of patients. And you can see that complete regression was seen, in 43% as against 25%. Time 3.6 months to 7 months. All right. So this is the best corrected visual acuity, which also showed a little better with ranibizumab with PRP, as well as central subfield thickness, which was better with the ranibizumab with PRP. So it showed the superiority of the combined treatment, especially in high-risk proliferative diabetic retinopathy. But this did not have the loading, so much injections like in Protocol S, which had a fixed dosing. So it has a short study period, and that is the limitation of this particular study. Then there is another study, aflibercept versus panretinal photocoagulation, just like the Protocol S. It's called Clarity, in which the BCVA changed from baseline to 52 weeks was what was taken. The best corrected visual acuity change from baseline to 12 weeks was the secondary outcome. So 116 patients in the aflibercept group, 116 patients in the PRP group, 3 loading doses, plus follow-up every 4 weekly. And then the other side underwent PRP alone. So total regression. The PRP group, the number of supplemental PRP laser required is 1.17. And aflibercept group, by 52 weeks, patient received 4.4 injections, and that was it. This also showed that there was superiority of BCVA as against PRP alone. But it's a 1-year study. Now, patients with macular threatening TRDs, or whether there is traction, injections can worsen the traction. So you cannot extrapolate this to all proliferative diabetic retinopathies. So selection between PRP and anti-VEGF, you have to consider, the ability to be compliant, because patients who lose to follow up with intravitreal injections tend to behave a little worse. That is what is here. So eyes who are lost to follow-up that required panretinal photocoagulation, which are stable over years, they will continue to remain stable. Whereas the ones in which there is an anti-VEGF alone, they may worsen if they lose to follow-up. Now, so fresh vitreous hemorrhage 2 weeks, unlasered patient, you can wait for the hemorrhage to absorb, or probably give an injection which can give us some time. So over 3 months, 4 months, you can complete the PRP. Multiple neovascularization in one quadrant, you could, if there there is no traction, give one injection followed by laser. So I did one study, a retrospective analysis of 568 patients. So this is before protocol. So I had 2 eyes of the patient who had PDR. The worst eye received injection with PRP. The better eye received PRP alone. And this was the total results. About 50% of patients had improvement in vision, 1 line, 2 line, 3 line, and 4 line. And about 30% people were stable. Bevacizumab with PRP versus PRP alone, you can see that a high percentage of patients of combination treatment had improvement of visual acuity, and a high percentage of patients with PRP alone had worsening of visual acuity. So currently in my practice, if there is no traction, if there is florid proliferative diabetic retinopathy, I would try to give 1 injection complete laser. That is a recommendation what I think it is good. PRP is still the first line. There is nothing to beat PRP. Posterior pole disease, you could put 1 neovascularization. You cannot laser the posterior pole, obviously. So pre-vitrectomy, and when PRP may hinder occupation. So in Indian scenario, 1 anti-VEGF followed by PRP will be a little better, as shown by study also. Thank you.
Thank you, Gopal. Very lucid talk. I just would like to start with Dr. MPS. Many years ago, I think, just when Protocol S had come, I remember him telling that he had given a doctor-patient only anti-VEGF as treatment for PDR and had not done PRP. So is that patient still okay? Is he still on anti-VEGF only?
He was actually severe NPDR, not PDR,
Okay.
but he is still okay. He is not had like PRP as yet, so he is still on follow-up without PRP. Yes.
So any PDR patients you've only done Protocol?
No, none subsequently, because like of the costs involved and the regular follow-up. Regular follow-up is
required.
something which is very important if you were to do the only anti-VEGF. That's a limiting factor. Other one was like the visual fields. So that Dr. Gopal did show the visual fields. So despite the fact that like the anti-VEGF does not destroy the photoreceptors, there was a decline in the visual fields sensitivity. So though not as much as the PRP. So that's something which is unexplained as yet. Why the visual field sensitivity decreases just with anti-VEGF agents also.
So what is your take, sir?
I would not, you see, presenting these 3 studies does not change my mind that I will shift towards anti-VEGF agents. The PDR laser because more than 3 decades back, what we have done, patients towards young IDDM, still maintaining 6/6 adequate laser, no need of injections. So many patients are there, not one. So, but there may be some set indications that despite PDR, if patient has recurrent ooze, despite good laser, you see, we should not say despite laser, despite good laser, because good laser is not, all PRPs are not good laser. We see every day so many patients. Patient will come, say, Doctor, I had 4 sittings of laser, 5 sittings, but still that may not be a good laser. So if despite very good laser, patient has ooze, then I may consider adding anti-VEGF. Or if the frond is large, very large frond, which is slightly closer on the posterior pole, then I may add 1 injection. I may start with 1 injection, but laser still remains the mainstay. So till the time all PDR I have lasered adequately in a very good linear fashion till maybe beyond vortex and also. So anti-VEGF for me has an adjunct role, not a primary role.
Uni?
So I'd like to just add one small point to it. I'm very fond of ultra wide field, and I think that is going to change the way we are managing these conditions by not a replacement, by modifying and making our PRP just the amount that is required. So in future, recruitment of more PDR, that is treating PDR by seeing more of the peripheral NV is going to be an important point. Second is identifying the areas of ischemia and probably intensifying your laser at that point would reduce the field loss, reduce the amount of complications that are full PRP, and it can be done in a sequential way. If you take care of the CNP areas to a great extent first, that could itself produce the amount of regression you are looking for. And two, there is also I think it's a paper about the increase in the peripheral CNP areas because of use of anti-VEGF, and that could explain the field loss because of anti-VEGF itself. And one last point is that when you give anti-VEGF in NVE, we should also be very concerned about the crunch phenomena. The crunch phenomena is when you have neovascularization. I personally think when you have an NV at the arcades and it crosses the arcades into the posterior pole, like it straddles the arcades, those are the highest chance of getting the crunch. The whole arcades crunch and cause a TRD. So when you have these NV only on one side of the arcades, they don't tend to crumple up like that. But when you have multiple attachment points and you give an NV and you don't have control after the tractional component increasing after that, and that is something to be very aware of while giving anti-VEGF.
I just wanted to add one point that of late I have been seeing patients being referred or coming for a second opinion where they have received intravitreal anti-VEGF for VH. It's not even a known PDR patient so many times. It could be just PVD-induced VH, it could be traumatic, but that is not, it's not a panacea. You know, anti-VEGF doesn't take care of the VH. I think that point, because anti-VEGF has become accessible and affordable and easy to inject, it seems like it's a one-stop solution. That message should go strongly that there is a reasoning why anti-VEGF is being given. I don't know if anyone else on the panel has the same issues, but we are seeing a lot of, unrequired injections also being given for VH. So I just was asking, sir, is there a role of anti-VEGF injections, especially when you have an ooze post-vitrectomy?
In unlasered patient, no, never, because a big no. But in lasered patient, yes, you can. But it's not affordability, ease of injection, it's, I think, faster money.
Just taking the clue from Dr. Verma sir's talk. I'm just sharing my experience with a patient, one middle-aged lady, type 2 diabetic. She was presenting with proliferative diabetic retinopathy. I kept her on laser. She was very closely monitored, and I did a good laser in both the eyes. But she kept on having, small oozes, and then she developed one eye macroedema, which I treated with injection, anti-VEGF, and vision improved to 612, but often I find in these patients, they develop sort of a fibrous proliferation over the posterior pole, and that also accounts for the decrease of vision. So, and these cases differ in their course of progression. Some of them, they involute quite well with the response to the laser, but some keep on progressing. So, as you have said, adjunct anti-VEGF works, but this often is difficult to control maintain the vision because of the proliferative changes, the fibrovascular changes in the posterior.
No, adjunct VEGF does not mean that, they may require 1 or 2 injections. They are not maintained on injections. See, by and large, we have to pay attention because diabetic patients, remember, it's a metabolic disease. So you have to encourage all the controls of all the factors. Ultimately, if the laser is good, but I agree with Unni's comment that all of us should have access or should do, if not ultraviolet, if single frame, even with 50 degree, you can have collage prepared. But if everything is very well lasered, then this problem may be less. But if you depend only on anti-VEGFs, then this crunch phenomena and TRDs, posterior pole fibrosis, that may still occur. The fact that in case your patient has precipitation of fibrosis does mean that there is some activity going around. Some going around means there is VEGF being produced somewhere, and so that you have to take control, because laser also is anti-VEGF only. Laser destroys the anoxic area, so that hypoxic area, so that there is no production of VEGF from that place.
Sir, so the if you compare injections alone versus laser alone, it's a non-starter, because obviously laser is important. The question here is about why not get the benefit of one injection, which will quell the neovascularization quite well, and then do laser, which will reduce the number of vitrectomies that we are doing.
Yeah. But the problem, one injection is okay, repeat, because the problem, you rightly said, cost analysis has not been done. Because you can't maintain these patients on VEGF. I agree with one injection is okay, but message should not go that anti-VEGF is unlike DME.
Great. Thank you, Gopal. Next, I'll invite Dr. Pradeep Kumar. He will speak to us on the comparison between innovators and biosimilars.
A very good morning to everyone, and thank you for the invitation and to present my work. I'll be talking about innovators versus biosimilars. So I do not have any financial interest in any of the molecules which I'm going to be talking about, and the data which I am presenting is either from the Government of India available on websites, or it has been taken from the OEMs themselves. So what is our understanding of a biosimilar? So biosimilar is a drug which has been made in a slightly different way compared to the parent molecule and may have different substances in its constitution. But it is supposed to work just as well as the parent molecule for the drug to be given certification. So that brings us to the question that most of the biosimilars that we see are either equally efficacious to the parent molecule, or sometimes they are bio-betters in turn that their efficacy is higher. The thought of biosimilar being less efficacious is not scientifically correct, because unless the drug has equal efficacy, will not get an approval. The issue always came with standardization and quality assurance. And we have the story of Ranibizumab as a classical case study, where between 2015 to 2018, they had 4 reported events of adverse drug reactions. Certain batches were recalled, but 2018 onward, the drug has found a great percolation in our retinal practice, and today it is the leading anti-VEGF in India. So we know today that we want to know what is the spectrum of biosimilars which are available with us, how they are performing when compared to reference molecules, and how they perform when compared to off-label drug usage, that is Biosimilar, and we should talk about their comparison to newer anti-VEGFs. The topic of my talk will restrict to the first and the second point today. So talking about Ranibizumab, we have a gamut of drugs which are available to us. The principal one available in market for a long time is Ranibizumab from Intas. At Army Hospital RR, we have a pretty long experience with Ranibizumab usage. Next is Eccentrix, then Vizumab from Reliance Life Sciences, Osiva from Sun Pharmaceuticals, Ranizurel, Rani-Eyes, and all these manufacturers which have gotten approval outside our country and may enter our country sooner or later. So we have sufficient safety data and efficacy data for Ranibizumab, and just to highlight one simple case, this case of diabetic macular edema, first dose, second dose, and by third dose, you find that the anatomy of the macula is just as good as it being treated with Eccentrix. So we have an accepted data on 4-week durability of these drugs. 3 loading doses are advised, and adverse reactions are similar to Eccentrix, not more than that, and the drug is fairly cheaper, whether we talk about Ranibizumab or we talk about Osiva. With Osiva, we do not have a very long experience. It has been recently introduced, but the early reports are quite promising. We have heard the work of Dr. Jayashet, and we believe that this drug is likely to do very well in future. Ranizurel again has a similar success story, and how these biosimilars changed our practice is the interesting thing to know. At RR, our consumption is about 3,000 doses a year, and when you look at the data of 2018 till date, when we look at the total number of injections which were given, the chunk of injections were Ranibizumab, and out of that large chunk, Eccentric used to enjoy predominance till about 2020. And in 2021 onward, we can see that there has been a surge in the usage of Ranibizumab, and in future we believe other biosimilars too. Now we talk about another anti-VEGF, because my topic has been to compare the biosimilars with the innovator molecules. So we have a new innovator molecule called Ranibizumab, and aflibercept, which has been around for about 10 years. So when we talk about aflibercept, the biosimilar from Intas is likely to enter the market soon, and we are all eagerly awaiting the arrival of that drug. So again, the change in our practice. I had not shown you earlier that how the ranibizumab chunk was changed with the other longer acting anti-VEGFs. So from 2020 onward, we started using more of aflibercept and brolucimab. I'll come to the reasons why. And the predominance of brolucimab in our practice has increased. So the take-home messages till now are that the market share of ranibizumab is reducing. So does the total number of injection. The newer anti-VEGFs do give better durability, but we have our reservations with reports of IOIs with brolucimab, also with faricimab, which is going to be introduced. Even before its introduction, the reports of IOIs have started pouring in. So to tell you about the efficacy of brolucimab, we did a small study in diabetic macular edema using a reduced dosage, that is 3.6 milligram dose. This compares to about 0.03 ml in your vial. We had two subgroups, equally matched in age and sex, and you look at this box and whisker plot, the change in visual acuity from first week till about 28 week, and this is the 6 milligram chart, this is the 3.6 milligram chart. They both look amazingly similar, and we talk about the best corrected visual acuity and the central macular thickness reduction. They're almost identical in both the subgroups. So the 3.6 milligram dose, that is almost half the dosage of brolucimab, is working equally well. Why we did this, I'll be talking about it soon. The number of injections in two groups were also far lesser as compared to our experience with ranibizumab. Serious IOIs did occur in both the groups, could be managed with local peribulbar steroids, and we did not have to shift any of the patient to oral steroids. We have had a very long experience with drug, this particular one, brolucimab, and we published our data of neovascular AMD way back in 2022, where we brought out that the inter-injection interval with brolucimab ranged at a mean of about 14.2 weeks compared to 6.8 weeks with aflibercept. So this drug definitely had a longer durability. We have extended the indications of brolucimab in our practice, and as I told, we are still awaiting the arrival of faricimab. So this brings us to the point that biosimilars, yes, they have very good efficacy as compared to ranibizumab, that is eccentric, the parent molecule, but the longer durability is definitely there with the new parent molecules, the innovator molecules. But what needs to be answered is that why then we are not adopting biosimilars across the country? This question needs further look into the pharmacoeconomics of anti-VEGF. I'll be cutting short on this particular part. The treatment cost, as we all understand, they not only involve the direct medical cost of the injection. There are indirect medical costs, the cost to the hospital in providing the OT, in providing the staff which is going to give the injection, and the loss of man-work hours which occur especially in our country, where an elderly gentleman is always accompanied by one healthy person of the family whose productivity is lost. The disease burden as of today, when we look at neovascular AMD alone, is close to about 6 lakh patients requiring anti-VEGF injections per year. When we look at the sale figures till about 2022, we see that there was just a sale of 1,14,000 units of anti-VEGFs, and the market share of 322 CR of anti-VEGF usage does not fill in this gap of about 4.5 lakh unmet need patients. The sale of ranibizumab has been steadily increasing. This solidifies our argument that biosimilars are doing well. But the question that remains is that these 6 lakh patients will require close to about 18 lakh doses per year, and the current approved sales are just 3,18,000. So what is happening to all those unmet need patients? Either they are being treated with off-label drugs like bevacizumab. I am not against bevacizumab, it's a wonderful drug, but the off-label nature of this drug makes the administrator, the doctor, prone to medico-legal hassles in future. So the way forward is more penetration of biosimilars which can have reduced dosage, one. Second is using longer durability drugs which reduce the total number of injections which are required. And our approach at halving the dose and halving the cost required to treat a patient may go a long way in at least reducing the burden of DME patients requiring this drug. Thank you so much.
I have one question. How was it 3.6, the half dose? How did you come to that?
Okay, so the approved indication for Ranibizumab for diabetic macular edema as per US FDA was 0.3 milligram and 0.5 milligram for neovascular AMD. When we had approval of Biosimilar, it was for 6 milligram for neovascular AMD first. So when you go with the fractionation, it is 3.6 milligram. Why they had chosen 0.3 milligram to be tested in their patient was also for one reason, because in the syringe, you can only fractionate it to 0.03 ml. There is no demarcation line between 0.02 and 0.03 ml. So when you go to 0.03 ml, you are left with, if you are taking Ranibizumab, 0.3 milligram. If you are taking Biosimilar, 3.6 milligram. That is the logic behind this dosage.
So you didn't do an exact half though?
No, we did not do an exact half dose. That is what I brought out. It is almost a half dose, but it is 3.6 milligram, because if someone says they did 3 milligram, I'll be surprised how they quantified
Got it at 50%, okay.
Hello, sir.
Yes, sir.
Do you advocate biosimilar be used in ROP, or do you have any evidence or data it being used in ROP?
Yes, sir. And in fact, on that account, there is a study from RP Center which talks about use of Ranibizumab in ROP. And we are also using Ranibizumab at our center in ROP cases without any IOI seen till date.
Okay.
So any thoughts, sir?
I'm not sure as to why the 3.6 was equivalent to 6 milligram. I'm not sure as to why. Because the whole concept was that we give more dosage so that it lasts longer, but then the duration of the efficacy as well as the number of injections seem to be the same. That's something which was surprising. In fact, right now, actually, I go the other way around. Aflibercept, I usually give 4 milligrams now, because that's how much you get in the vial. So I do give 4 milligrams. And I can't say that it lasts longer. Probably I'm giving the best, because their studies have come up with 8 milligrams.
8 milligram, yes.
So, but we don't have an 8 milligram, but what is there in the vial, about 0.15 is there. So we are able to comfortably give about 0.1. So that's what I do. I'm surprised with the other way around results of this.
So routinely all patients receiving Aflibercept, you're giving almost the...
Yes, but only thing is you have to do a paracentesis, because
Yes,
the
because the
IOP does
volume
go
is
up.
high.
So I do now, of the last nearly about a year, I have been giving 4 milligram, though we have not published the results. But then just on a gross, when we looked at the duration, it seemed to be almost the same, probably another 2 weeks extra we get.
6 weeks. Okay.
So we also tried actually 100 patients of Aflibercept, in fact we gave 5. So, but honestly, those 100 patients did not show any additional benefit to the 3 milligram.
So do you think 8 milligram is going to make a difference? I think the reasoning is something else.
Probably the reasoning is the same. The higher, as sir said, the higher
Molar dose.
the molar concentration. That's the same thing that is happening with Brolucizumab. Probably we are giving much more that is actually required to create a response, but we are giving the extra dose for the duration.
So I was hoping that with the 3.6 IUI maybe less, much less.
Sir, the data, the number of patients that were recruited were very small. As I told you that these patients, 44 and 42 patients receiving 120 odd injections each, having one IOI in each group, we cannot really comment on the incidence of IOIs because of the different dosages. By far, we have completed 1,770 injections at our place. We have had 4 serious IOIs. We have not lost a single eye. So that is what we can share in the long term. So there is nothing to be, I should say, afraid of Biosimilar as a molecule. It's a wonderful molecule, but one has to be careful and the patient has to be counseled before giving the molecule that we are giving you a stronger drug, but please expect a stronger reaction as and when it happens.
So futuristic, you showed the wonderful graphs that biosimilars increasing,
Yes, sir.
the innovators decreasing,
Yes, sir.
long duration molecules increasing.
Yes, sir.
So ultimately, I foresee this thing that after some time, both this, biosimilars of Ranibizumab as well as innovators, they will reduce much, and then duration molecules will go higher up.
Absolutely, sir. Absolutely. And once the biosimilar of aflibercept comes in, then the final touch will come when the innovator molecules may disappear from our shelves. I'm not claiming anything, but that may happen. But brolizumab and faricimab, for them to stay in the market for a long time, we'll have to see the long-term result. With brolizumab, I'm quite sure it will stay for a long time.
Okay, thank you.
Thank you.
I think now we have the last talk of the session, and that is by Dr. Chaitra Jaydev, presenting her data on OSIVA.
Thank you very much, sir. It's our data, our experience. It's not a single center. We did it across 5 centers just to get a quick idea of whether this drug works well across a few indications. Okay, my slides are not moving. Slides are not moving. Okay, so this was the OSIVA study group. We had Dr. LV leading from CFS. We had Dr. Manisha, Dr. Rupa Kanti Biswas, Dr. Divyansh, and myself. We put together data and no financial disclosures, just to get a idea of how this drug works for us. This is the study which actually showed us how many injections are recommended for the patient and why they don't take it. Most of them don't take it either because of the repeatability of the treatment required and also because of the cost involved. So yes, there is a mismatch between what is recommended and what happens in real life. And like I mentioned, cost is the biggest factor. Now, this is the study that looked at a 6-year analysis of the impact of anti-VEGF treatment and the patient characteristics on vision outcome. Here, with that cohort of a very large number, with the first anti-VEGF injection and at least 2 years of follow-up, they brought out the visual acuity data. And if you can see here, after modest mean visual improvement with intravitreal anti-VEGF at year 1, patients netted a loss of visual acuity by year 6, which means they really need to keep taking injections till that time because there's a fallout. Injection frequency eventually decreased over time, and this was paired with a relatively high rate of discontinuation, which is probably the reason again why there's a drop. And the modeling suggested that more frequent injections were associated with better visual acuity outcomes. But unfortunately, again, affordability and compliance becomes an issue. And there was difficulty with continuous adherence to frequent intravitreal injections that may have contributed to under-treatment and therefore less optimal visual outcomes. So this is almost a 6-year follow-up, which means that even at 6th year, we tend to tell the patient by the 3rd or 4th year, the number of injections required comes down, but apparently not from this particular study. So why is there a need for biosimilars? Because the innovator molecule, though extremely efficacious, it is not affordable for many patients in developing countries or a country like ours, simply because of access to healthcare is less. Private insurance is not affordable for all. So biosimilars have made this treatment more affordable. We have many biosimilars at our disposal. Let's quickly look at the cost comparison between biosimilars and innovators. If you see here, there's something called as cost of injection to the patient, to the doctor and to the patient. To the patient, we need to add a whole lot of other things like consultation, their travel, their OCT, etc. So when you look at the yearly cost of the drug, depending on 5 to 7 injections probably, you can see that the cost difference is quite significant between the innovator and the biosimilar. And then when you add the travel cost to it, it becomes exponentially more. So these are the numbers that we need to keep in mind when we are advising injections for our patients, especially because at tertiary referral centers, we do get patients from out of town, and sometimes their travel cost tends to be more than the drug cost itself. Now, coming next to the reduction that we see when we use a biosimilar over an innovator, it's at least 40%. So that advantage the patient should be given because of the number of injections involved. So the era of biosimilars is here. They have comparable efficacy, safety, and duration of action. The production is cost effective because they are manufactured locally. They don't need to be imported. And this has also led to their worldwide acceptance, as mentioned in the previous talks, of the different biosimilars that are available even outside the country. Now, this is an important Cochrane review that will come up soon. It's still in process. They are looking at the anti-VEGF biosimilars for macular degeneration. This has been started in 2023, and this is how they're going to go about it, the different studies, the participants, the interventions, and the outcome measures. So to quickly tell you the outcomes expected, they are going to look at the change from baseline from 8 to 12 weeks with the biosimilars. They're looking at the proportion of participants who lost vision, and again the composite scores of visual quality indices, the proportion of participants who had serious ocular events, who required treatment, the adverse drug effects, all of this. So this is going to be an extremely important and comprehensive review which is in process and awaited. So now let's look closer home, insights into the VRSI survey on biosimilars that was conducted. You can see here the price points were discussed in this survey, which was important, and also the graph shows the willingness to pay price of biosimilars as what we perceive as the caregivers. We also saw changing in trends in the use of anti-VEGF amongst our peers. A lot of them were, similar compared to the respondents. We will see here that the majority of the respondents actually believe that biosimilars have made anti-VEGF treatment more affordable. So these are the different biosimilars. I think except for Optimab, almost all the others are available. Currently, Optimab is not there for use, and you also have few FDA-approved biosimilars as well. Now coming to the drug in question, Ociva, this is an Indian biosimilar. It has completed its phase 3 and it's been approved as of April 2022 by the Central Drug Standard Control Organization. Now coming to our experience, we wanted to look at the safety and efficacy of Ociva in maculopathy secondary to common retinal pathologies that we see in our practice. The study period was between July 2022 and September 23 because we wanted to have a good follow-up on these patients. Both treatment naive and pre-treated patients who received at least one injection were seen for at least one follow-up to see the response. Commonly used conditions such as DME, CNVM and RVO were included. We looked at the visual acuity outcome and the central macular thickness determined before injection and at 4 weeks post-injection, and any intraocular information if noted. So this was the demographics, the mean age in years. And for the diagnosis, we had a maximum patients with DME and followed by RVO patients here. Others, we had, a couple of cases we couldn't analyze too well. This was for PCV, pseudophakic CME, and radiation retinopathy associated CME as well. So the average number of injections received in these patients was 1.3 with a maximum of 121 patients receiving at least one, and then we had 2 and 3 and 4 injections as well. Now, if you look at it, we had more than 50% of patients improving. We had some of them being stable and some of them actually worsened. This was mostly associated with their systemic condition as well. If you see in this CMT as well, at least 70% of them had pretty good improvement, and some of them also deteriorated, which is about 9 patients in this whole cohort. So yes, it was efficacious, improved and maintained in at least 88% of the patients, and close to 90% of the patients had a reduction in their CMT or maintained. It was effective in all subsets analyzed in the data, including the conditions that I mentioned. And the BCVA improved in or maintained post-second injection also in a fair number of patients. We did not have any intraocular inflammation, endophthalmitis, optic atrophy, or any of these that we have seen, with new anti-VEGFs, and we did find it to be a rather safe drug. So I'm going to skip the cases because we have quite a few of them, and I think we're almost time here. Just passing through, you can see the improvement in vision with this particular molecule that we've used. I'll just run through the slides. You can see even large edemas like this, we saw good response. Here again, subretinal fluid and intraretinal fluid has started showing response here. Couple of other cases. Just to show you the entire spectrum, this patient even had an ERM, but good response. They're just some of the cases that we have. So just want to tell you that Osiva is safe and efficacious. It is a good alternative to innovator molecules that we have. It makes it available to all because of its affordability, visual outcomes, and an accepted safety profile. Makes it a good option for our patients in our countries. Thank you so much. This is something that probably give you confidence. Close to 25,000 vials have been used so far, and there have been no major concerns. Thank you.
Thank you, Dr. Chetra. See, one of the main concerns about biosimilar or to that matter, any new drug is you're worried about the intraocular inflammation and the possible side effects. So when you're starting a new drug, how would you, in your practice, how would you set up the evaluation process to make sure that you don't end up in trouble?
So any obvious, telltale signs of inflammation, we do address that first if there is. And for most others, if you will ask me what's your drug of choice, even if there is some minor amount of inflammation, we really don't have an option because most of them are insured by central or state government agencies wherein only a biosimilar is approved. They do not have access to innovator molecules. In fact, one of the agencies even sends us a note back saying use 3 injections of the biosimilar and only then send for an innovator molecule. So that is one limitation that we have currently, at least in our state. I don't know about the other states. But if there is a frank inflammation, I would be skeptical because we have seen flare-up of inflammations. And of late, since Dr. Padma spoke as well, we've had young patients after the first injection of biosimilars, the inflammation, new onset inflammation coming in as well. So to the point that, we do get recommended by the UVA department to avoid it in certain conditions.
Just one point I just kind of wanted to add over here. Some of the new drugs which actually produce intraocular inflammation, without regular follow-ups of seeing the patient after 1 month, you might miss subtle anterior chamber reactions that happen in the first week or 2 weeks. So I would suggest that whenever you're using a new molecule for the first time, you probably have to do even a thorough slit lamp examination to check whether there are anterior chamber reaction, because it may not affect you the first time, but the second time you give the drug, you might end up in a massive intraocular inflammation. Doctor?
No, that's where the monitoring committees come into play, because so that the benefit of doubt is spread, the word is spread to the rest of the community. So VRSA does have adverse event monitoring like a committee, and you have a form in which, if in case you notice an inflammation after using a biosimilar, if you can fill it up, then the news gets spread faster, so that people probably are much more careful when they use it. I'm sure R&D Ophthalmic Society also has one, so I would suggest all of us use that. Another thing is even with Ranibizumab, there are papers where they have given this along with the subtline on steroid. So that has decreased the incidence of inflammation quite significantly. So there is a Japanese paper where in every patient where they have given Ranibizumab, they have given a subtline on steroid and found that there was hardly any inflammation at all. That's another thing which can be considered as well.
A lot of this inflammation also tends to subside with just topicals. There are few reports itself which have said that they've needed a systemic intervention. Most of them tend to subside with just topical steroids.
Another major advantage of biosimilars is it has allowed us to move away from using Biosimilar, which has put us in some kind of medico-legally unstable territory.
Because it's a non-approved.
I want to ask, sir, how will you differentiate between this post-injection inflammation and post-injection endophthalmitis when the patient presents to us?
The post-injection inflammation, there are markers, but cannot be an 100% surety. The post-inflammation inflammation, usually the patient doesn't have pain. There is no lid edema. There is no circumcorneal congestion. There's no conjunctival congestion. So these are signs which you can see that actually the eye is quiet, but there is some amount of inflammation in the anterior chamber as well as the vitreous. particularly the vitreous, and the patient complains of decrease in vision. So you can make out the eye is relatively quiet, but then, like, of course, you can never assume that it is going to be a post-inflammation. Like in such a situation, what I would do is to do an anterior chamber tap, send it for a smear culture, as well as probably give an intravitreal antibiotic under steroid in the first instance, and then subsequently follow it up with steroids. But like you can make out that the differentiation can reasonably be made out.
Do we have any more questions?
I think we can call it a day. Thanks everyone for your participation, and thanks to the chair and panelists and speakers. Thank you.